It's a pleasure to be here. I want to thank my host Rick Schmidt for inviting me, and Rhonda Sharman for hosting me a number of years ago. I don't know how many of you were at the course I did in the Solomon Islands. Anybody here that was at that program, the convention? But it's beautiful out here, and it's a pleasure to be back. I had dinner last night with Tony and Rick, and just really nice here in Annapolis. I had planned to bring my family. At the last minute, canceled all the flights, rebooked them for about 2 weeks from now, because my son, who's had like a rotator cuff problem that I couldn't fix for the last year and a half, just started playing baseball again and has a big tournament this weekend, and my daughter has a softball tournament. So I would have had him with me, but I'll tell him about Annapolis, and I hope we have a good weekend here. This start is going to be one of the only times I'm going to have you sitting. We're going to be doing hands-on all weekend. We're going to start this morning with a functional assessment lab. Everybody's going to find out on their partners what their functional screen score is. We're going to be screening each other for posture, balance, coordination, strength, flexibility. In particular, mobility and stability. We're going to be looking for painful movements. We're going to be looking for painful postures. We're going to be looking for painless dysfunctions. The painless dysfunctions are the hub of the rehab paradigm. The painless dysfunctions are what we look for in all of our patients so that we can get to the source of their problem. The beautiful thing about a functional approach, or the functional pathology of the motor system, is that we're not tied down or anchored to the person's MRI or their X-ray or static findings or merely just the anatomical findings. We want to take a step back and we want to see what's working and what's not working, and we want to improve function. Every person that we see can benefit, whether they have pain or not. A lot of your patients are going to be people who want to build their athletic functional capacity. So what we're going to go over are techniques that you can use on children, you can use on somebody who's 40 years old, loves to go cycling, they have friends who've had knee problems, they don't have any pain. It's a preventive approach. You can work on an elderly person whose son or daughter has brought them in because they've had a heart problem or a stroke, and now the person isn't the same as they were before. It might be an 85-year-old. It might be somebody now who's not as stable as they were before. They may not have any pain. They might fill out your forms in your office and your visual analog scale, and there may not be any pain, but they may be there for some functional reason. At the end of the day, rehabilitation is about restoring abilities, and the rehabilitation model has gone through a lot of permutations. The first permutation in rehab was when the physiatry profession, the physical med and rehab profession, was first hatched. After World War I, due to traumatic injury, there were many, many soldiers who required some rehabilitation. They required restoration of function. And the functional approach has always been a parallel pathway to orthopedics. Chiropractic was doing physical therapy before there was a physical therapy profession. And chiropractic has always stood for restoring function, not for treating what? Treating symptoms. And how do we build function? By focusing on the nervous system. The nervous system now, we understand the processes of how children who want to sing or play tennis or play a musical instrument develop talent. We know it's via the nervous system. We know it's not just something that's innate, it's something that can be taught. Dan Coyle's book on the talent code talks about the neurological processes that we now can appreciate and understand about glial cells, the glue binding the neurons. We now understand more about how myelination occurs with respect to movement patterns.
Sorry, folks.
And myelination is going to be something that will be a theme for us this weekend. When we assess functional capacity on each other this morning before lunch, we're going to be looking for myelinated programs of movement that are disturbed, that are faulty, that are things that we want to transcend, things that we want to re-educate, that we want to transform. Our patients come into us with symptoms, but we want to get to the source of their symptoms, and the source of their symptoms is in painless dysfunction. So we're going to be taking a step back. We're not going to be reductionist like the medical model, which wants to look at smaller and smaller parts. We're going to take a step back and look at the person. And that holistic approach starts by looking at a person's functional capacity. Of course, we're also going to take our history and we're going to look at what they do, what their needs are. And if their demands are high level, then their capacity better be even higher. And if their demands are low level, their capacity still needs to be higher than their demands. If there's a capacity shortfall, there's a high injury risk. Our job is to find out where that risk is and where we can make an intervention. The intervention that's most conservative, that's most straightforward, that's most immediate is an intervention in the realm of functional pathology of the motor system.